in there. So I think the original agenda said post-transplant follow-up for Krabbe, MLD, and ALD. And I think we could have an entire week-long conference just on that. So we're going to limit it to Krabbe today. That's why Krabbe is in parentheses there. So as a community, I think that we've really made tremendous progress over the last year and a half or so with getting kids to transplant, getting them identified through newborn screening, addition to the rest. But we heard yesterday about more and more states coming online soon for Krabbe newborn screening. We have guidelines for what to do with children that are identified by newborn screening. First, set of guidelines came out with Jennifer Kwan as first author in 2018. And then Rob talked about the one that's in preparation now. And then we also have surveillance guidelines for late onset disease identified by newborn screening. So now that we are diagnosing them and getting them to treatment, now what? Well, their post-transplant monitoring is very important. And I think the Children's Oncology Group and other transplant organizations have made very clear recommendations for monitoring long-term complications of treatment that's more therapy focused rather than disease focused. So now our job as, what happened there? Oh, the touchpad. Okay. So our job as experts and advocates for the specific diseases is to come up with disease-specific long-term monitoring for complications of the disease itself. And as we are all aware, there's no standard guidelines for doing this. So what I'm hoping the next 20 minutes is going to be is a continuation of this discussion that we've had in bits and pieces over the last few years. But now that we've gotten on the RUSP and we're getting this new newborn screen guidelines paper out, now we can hopefully put some real substance to this discussion over the next year. So for people that might not be as familiar with post-transplant follow-up in general, this was adapted from a paper that was written for primary care physicians for adults, and I think adults and children, but for primary care physicians who may need to partner with, partner locally with far-off transplant centers to make sure children get all these tests, all these follow-up exams after transplant in general. So if we want to, this is a very sensitive touchpad. Okay. So if we want to standardize follow-up, I think we have to ask, what is the goal of the standardization going to be? Is it educating providers who may be partnering with far-off specialty centers to make sure that children get the truly clinically indicated, clinically necessary testing that's used for care of the patient directly in front of them or in front of us? Or are the guidelines we want to set up informed with our academic interest and hope for the future for informing clinical trials and future therapeutics? And for that, guidelines would be used to standardize ascertainment of natural history and inform clinical trial design. So as more and more states come online, more and more kids are going to get identified and treated, and the LCN centers will really be the go-to centers for follow-up after that acute phase of transplant follow-up is over. And potentially LCN centers will then also need to partner with neurologists or even pediatricians closer to the child's home to make sure whatever it is we say needs to happen does happen. So one of the things I would love to open the floor to a little bit later in my time up here is a discussion of what sort of follow-up do we really want to ask for. So before we can really say what do we want, I thought it would be important to figure out, well, what are we doing right now, or what are we intending to do for those of us who might be seeing patients anytime soon as our states come online. So I developed that survey that you heard about last night, where I wanted to survey LCN clinicians. And this is for anybody, not just neurologists, it could be complex care, transplant physicians, anybody who has an opinion is welcome to express it through this survey. And so far we've had 12 respondents. If you haven't responded yet, it's not too late to participate and express your opinion of what patients should get or what you do use if you do follow patients. 11 of those respondents were neurologists, which I don't know, Anna, if you know how many neurologists we have like really closely associated with LCN. Not all of the centers have neurologists as their center directors. So I think we have pretty good representation of the neurologists that are very directly related to LCN, but not all of you have. So who responded so far? Most of the respondents, so the questions were worded, how do you use testing? Or if you were to follow a patient, how would you use testing if you don't already follow patients so far? And so for a lot of the respondents, the question of follow-up is really a hypothetical one because of the 12, 7 have not actually followed a Krabbe patient that is post-transplant. So the figure on the left here is just the distribution of how many total patients with infantile Krabbe have you seen in the last 10 years, with 0 on the left, and on the right is phenotype undefined, unclear. And the figure on the, so I'm guessing that might be like kids at risk for late onset that were identified through newborn screening. And then on the right is how many Krabbe patients who actually received transplant. And most of those, all of us who responded to the survey who followed transplanted kids have had at least one of those children we follow transplanted at our home institutions. So I thought this was a good result here. First, before we talk about post-transplant, what tests do we need pre-transplant? And everybody agreed MRI, nerve conduction study, and GALC genotyping would be necessary before transplant. And I'm assuming that because these are infantile babies, probably people were assuming that we already had a cytosine and a GALC activity level, because that's how they would have been found out. Other popular tests pre-transplant were whole blood cytosine or RBC cytosine, auditory evoked responses, and EEG. The next question was, in general, what sort of tests would you find useful in monitoring Krabbe after transplant? And the highest bar here, MRI, was just over 80% felt that that would be a useful test. Nerve conduction and developmental testing were the other winners. So the next few questions asked, how often would you do certain tests in the first year after transplant, in the second year after transplant, years 3 through 5, and then greater than 5 years after transplant? And the way this figure is set up, blue is the proportion of respondents who said they do the test every 3 months, red is every 6, and green is every 12. So blue, red, and green are test utilizers. The purple is never, and the blue is only with signs or symptoms. So in the first year after transplant, everybody, not everybody, but the majority, 80% would do at least 2 MRIs, at least 1 nerve conduction, and at least 1, mostly 2 developmental tests. So MRI, cytosine also, and then developmental testing. Nerve conduction just every 12 months. Many would also do biochemistry, but the electrophysiological tests other than nerve conduction were much less popular. In the second year after transplant, pretty similar, lots of MRIs. But now instead of 2 MRIs in that year, just 1 MRI, and lots of nerve conduction studies. So summarizing that, the second year after transplant, people would generally do 1 MRI, 1 nerve conduction. Interestingly, there was a lot of enthusiasm for every 6-month developmental testing and not much enthusiasm for biochemical. In years 3 through 5, naturally, testing frequency would decrease, with now most studies being obtained only if signs or symptoms, which is the blue, and then the green is every 12 months. So developmental testing still has a big role, with being done about every 12 months, and about 30% would do MRI and nerve conduction every 12 months. Once the patients hit 5 years, there's a few of us that are still doing scheduled testing, especially developmental testing. But generally, this is, people thought that this should be directed by signs or symptoms. And then there were questions about workup for specific complaints, new findings on exam or new complaints. So, I just said, okay, if your patient had new finding of ataxia on exam, what test would you be likely to order? MRI and nerve conduction, hyper or hyporeflexia, MRI or nerve conduction, respectively. And then various types of regression were often evaluated with MRI and neuropsych testing, nerve conduction for the motor regression, and EEG for cognitive or language regression. I think opinions about when to use EEG were influenced by the identity of the respondents as being primarily neurologists, and generally speaking, they would only use EEG if there were signs or symptoms concerning for seizure or like cognitive regression. And I forgot the disclaimer at the beginning. What I'm reporting here are not recommendations. That's simply describing what the current thoughts of the respondents were. So for pre-transplant evaluation, over 80% agreed on MRI, nerve conduction, and Gaussian genotyping. Gaussian activity and psychosine were also very important, but I think we probably presumed that those were already available. After transplant, developmental testing, MRI, and nerve conduction important. In the first year, patients are still quite young, and we want to make sure they're doing okay, and they're not able to report their symptoms. So we're doing more tests. We're thinking of more testing in the first year, as well as the second year after transplant. But as I mentioned, by the time we get to the third year, it's much less protocol driven and based really on symptoms. Developmental testing remains very important, though, in everyone's mind. So as I mentioned, the general consensus was EEG only for clinical concerns. Developmental testing is very important. There were comments about how that could interact with the school system and how you could either rely on the school system to provide some testing or use testing to direct what the school system was providing. And I think, how individual clinics utilize that would in part depend on how available developmental testing is for them and also how responsive and resourced the school system is. I think that in light of our discussion yesterday about biochemical testing and genotyping and Gaussian activity, I think there's opportunity for work to be done just within our group about how useful are these biochemical markers really, especially after transplant when we expect many of these things to improve, if not normalize, regardless of how the child is necessarily doing clinically. So with that, we have about 9 minutes left. I know some of you have kind of pulled me to the side and given me some thoughts, and I think they're all really valuable. How can we use this information I just presented, which is just, our own opinions about what we might do or are doing. And, at a minimum, we could use that to kind of come to a consensus of what we think we should do within the LCN, because just like babies that are born on one side of the state line versus the other get different types of screening, I would hope that there's a certain standard of care that we provide in one LCN clinic versus another, since we're all under this umbrella. We can use the results that we do have to continue to evaluate the natural history we do have access to and educate ourselves as well as the general community about how these results are changing over time. And what's our goal? And this is obviously more than we can answer today, but do we want a minimum necessary data set, or do we want to wish for the moon, shoot for the stars, and kind of come up with data points that those LCNs and patients who want to participate in those data point collections are able to? If so, how do we fund that? And then how would this interact with the potential of future therapeutics? So that's a bit of the data summary I collected, and I would love to hear some of you all's thoughts on that.